Now we have come to the last leg of our presentation. This is to find how best to arrive at a best practice. Now in the introduction, the playlist 1 in the introduction, I had warned you that the practices are quite different and this subject is rather cluttered, with the practice being quite different from doctor to doctor, hospital to hospital, and even multiple guidelines and webinars have not brought uniformity in the practice. It might remain so even after my presentation. I also took you through the evolving concept. In 1970, the concept was that recurrent urinary tract infection led on to renal scarring, and renal scarring led on to renal damage, and that was responsible for good number of chronic renal failure in adult life. But that concept has changed, as we saw, considerably, and the pendulum has swung in the opposite direction very much. I took you through the literature review to make you understand what exactly is the evidence, published evidence of from the major journals, from reputed journals so far. And we took a bird's eye view of the guidelines. What was striking in the guidelines was that there was gross difference in some of the advices, and in some very crucial matters, some of the guidelines kept mum. And the most important crucial difference was about the ISPN guidelines, Indian Society of Pediatric Nephrology guidelines. What drives the practice, underlying factors which drives the practice are changing evidence and concept, that doesn't require any explanation. Antimicrobial resistance, including multiple drug resistance. You see, nowadays people are very concerned about this, especially the infectious disease consultants are not at all happy of giving antibiotics continuously without any rhyme and reason. Then, of course, is the practical thing. What you advise should be practiced by the patient. Non-compliance is a major factor in continuous antibiotic prophylaxis. When you advise antibiotic prophylaxis for somebody who is asymptomatic year after year, even during well-done studies, the compliance is only about 30%. And they say it is not even 5% in the general population. Therefore, when you are advising a remedy which is bound to fail, you have to have a second look at that. And nowadays, antibiotic stewardship is a very important topic. And IAP itself conducts many training sessions emphasizing scientific use of antibiotic and antibiotic stewardship. And on the next day, when you advise prophylactic antibiotic, for which there is no evidence now, it becomes something very contradictory. Now, one has to agree, however, that the multiple international practice recommendation also differs in some issues. In the midst of all this, we should find what should be the best practice. After all along talking about CAP and UTI, I would like to make a statement here that the prompt diagnosis and effective treatment of febrile UTI recurrences may be of greater importance regarding of whether VUR is present or the child is receiving antimicrobial prophylaxis. Therefore, the best for recurrent UTI is to treat promptly within, and all infants who have sustained a febrile UTI should have a urine specimen obtained at the onset of subsequent febrile illness and treatment started within 3 days. If you can do this, you have achieved your goal. You can forget about continuous antibiotic prophylaxis. But I'm sure most of the doctors in the third world countries would say this is not practicable, this is a utopian idea. But remember one thing, that practice is case by case. Many of the pediatricians today practice in private, where the patients do comply with whatever you say. Therefore, if you think that your patient will comply with it, he or she or the mother is able to get a urine done either in the lab or by a dipstick method within the first 24 to 48 hours of the febrile episode, and contact you and start taking antibiotics if there is UTI, that is the best thing. Forget about continuous antibiotic prophylaxis. But why 2 or 3 days? Now there is not much of evidence we have said. Still, we don't want to have a prolonged fever and an UTI in case the child develops a renal scar. Now, in case you can't do it, that's a different story. Now, I'll try to give you a synopsis of the presentation. Now, the best practice, this is a traffic light. I tried to put this traffic light colors. As far as after the first febrile UTI is concerned, there's no prophylactic antimicrobials between 2 to 24 months. So you should not give it, and therefore I've given it in red. This has been given in both, especially in AAP guidelines as well as in NICE guidelines. They agree on this. I must point out that the American Urological Society as well as the Indian Nephrological Society do advise after the first UTI. But I do feel that the evidence has swung so much after the 2011 Indian Academy of Pediatric Nephrology guidelines, and now there's no justification to give all patients routinely after the first febrile UTI. But everything is, this is an amber, may be considered case by case in special circumstances. Especially after the first UTI, you might give you in bowel bladder dysfunction, strongly proposed by the American Urological Society, and even UpToDate advises this. UpToDate advises also in special circumstances, like if you have a single kidney, a renal abscess, or a very severe attack and the parents are very concerned, and they're very much concerned, you will have to take it case by case. And they even advise in children who get recurrent febrile convulsions, may be very much upset psychologically, that you may have to give prophylaxis. You have to discuss with the parents the pros and cons and sometimes give it. But generally, no. After the first UTI, you resist from giving continuous antibiotic prophylaxis. Now, CAP may be indicated in children with grade 4 and 5 reflux. Remember, both AAP and NICE guidelines only say maybe. I think the AAP definitely says, I don't know about NICE guidelines, but you know, regarding this is because this is based on the Swedish study, which showed definitely in girls at least, grade 4 and grade 3 reflux, the prophylactic antibiotic decreases the renal scar. UpToDate also supports this. And therefore, this is a practice which more or less is done. You don't have to break your head too much on this, because grade 4 and grade 5 reflux is always referred to the pediatric surgeons, who definitely after, if they do surgery or not, put them on prophylactic antibiotic. Now, we said that it is maybe warranted after recurrent UTI. And put it in the amber zone because prompt treatment of urinary tract infections might prevent these children from getting continuous antibiotic prophylaxis. But what is recurrent? This is advised by the NICE guidelines as well as by UpToDate, but they define recurrent UTI in a different way. The NICE guidelines advises that if you have, in a very complicated manner, if you have 2 urinary tract infections, one of them is an acute pyelonephritis, then that is a candidate for, you can label it as recurrent UTI. If none of them are acute pyelonephritis, you only have lower urinary tract infection, then you need have 3 attacks to label it as urinary tract infection, recurrent urinary tract infection. They do not give a time frame for within which this should occur. Remember that in most Western countries, any febrile UTI is taken as an upper urinary tract infection or an acute pyelonephritis. And a child who has pain while passing urine and pus cells in urine with a urine culture positive without fever, and in which the DMSA scan, if done, is normal, is taken as a lower urinary tract infection. Now, the UpToDate defines it in a different way. They say that if you have 3 urinary tract infection within 6 months or 4 within 1 year, then you label it as recurrent UTI. I don't think many children will follow and will come under this grade. But whatever it is, recurrent UTI is an amber indication for giving continuous prophylaxis, antibiotic prophylaxis. Now, postnatal management of antenatal detected pelvic dilatation, even now I would put it in the green zone because it's very well practiced. The reason why you give it is at least till the investigations are over and you arrive at a diagnosis. Definitely everybody would like to give antibiotic prophylaxis. And sometimes initially it was considered that about 15% of the children with these antenatal pelvic dilatation develop severe UTI within 1 year and scarring. That was the reason why it was routinely advised up to 1 year. And many pediatrician neonatologists do advise that. But as I pointed out recently, in this month, in October 2020, Archives of Pediatrics have produced a very good article in which they said that it may not be necessary. But this has not come in the guidelines. Therefore, I would just put this practice in the green zone. And finally, remember one thing. Don't give it for asymptomatic bacteriuria or symptomatic bacteriuria in which there is no pus cells in urine because they are not UTI. This may look trivial, but many children are getting continuous antibiotic prophylaxis because they just had a fever and the urine culture was positive in spite of the fact that the pus cells was negative. This could be a patient with asymptomatic bacteriuria in whom you did a urine culture during a viral fever. One thing which I forgot to emphasize in the last slide is there is no indication to give continuous antibiotic prophylaxis in non-dilating BUR because of the simple reason that most of the grade 1 to grade 3, you don't require antibiotic prophylaxis. Only the Pediatric Nephrology Society IAP guidelines advises that, but evidence is strongly against it. To put it in a nutshell, your aim must be, the gold standard of treatment should be to give prompt treatment within 3 days of UTI as much as possible and avoid continuous antibiotic prophylaxis. If at all you start CAP in selected patients, use it for shortened times. With this, we come to the end of the presentation. You can find my other videos in this YouTube link. And I also blog on wordprocess.com, Pediatric Theory and Practice wordprocess.com. You can see my other blogs on pediatric topics. Thank you for listening to me so long.